Episode 17. Welcome to Sports Medicine Case Studies. I review published case studies in sports medicine. 14-year-old, otherwise healthy male, with well-controlled cystic fibrosis, presented to the emergency department complaining of severe muscle soreness in the calves, thighs, arms, and back, persisting several hours after completing a football training session on a summer morning. The practice lasted 3 hours and consisted mostly of sprints and distance runs. The ambient temperature ranged from 80 to 88 degrees Fahrenheit. He reported consuming only minimal amounts of water during practice to avoid vomiting and denied urination until about 8 hours after his first morning void. He had had no recent illnesses and no previous history of documented dehydration. His last hospitalization at age 10 was for a pulmonary exacerbation of cystic fibrosis, requiring a brief inpatient stay for IV antibiotics. He had been in good health and had had no difficulty keeping up with his peers in his athletic activities. Clinical findings. His weight was measured at 56.6 kilograms, down from 60 kilograms 8 days prior, representing a 3.4 kilogram loss. His heart rate was 95 beats per minute with a baseline typically in the 60s. He had diffuse muscle tenderness on exam. His laboratory studies demonstrated a sodium of 129, chloride 90, creatinine 1.2, creatine kinase 1,146, with the normal range being 39 to 308. A white blood cell count elevated at almost 20,000 with a normal differential. Hemoglobin and hematocrit were within normal limits at 16 and 48% respectively, but these were elevated above his previous baseline of 15 and 45. Urinalysis was normal with a specific gravity of 1.003, but this was not obtained until about 90 minutes after treatment had been initiated, which included aggressive fluid supplementation. So the differential I came up with, obviously he had hyponatremia. There was an elevation in CPK consistent with perhaps early rhabdomyolysis. Given his white blood count elevation, there is a possibility of systemic infection, and of course I think of heat illness. The author's diagnosis, and I'm going to quote this from their article title, was Hyponatremia-associated rhabdomyolysis. I'd like to recognize those authors, Doctors Kazkavge and Skalansky, who published this case study in the journal Pediatrics in 2012. It was a really well done article, and they report it's the first case study about exercise-induced hyponatremia and rhabdomyolysis in an individual with a history of cystic fibrosis. I'm Scott Hall, a primary care sports medicine physician, and I'm studying for my sports medicine recertification exam in 2026 by studying relevant case studies, and hope you'll join me on the journey. This podcast is for educational purposes only. Okay, outcome. So the patient was resuscitated in the emergency department. He was given normal saline by IV, 2-liter bolus over 2 hours, then a 3rd liter at 500 milliliters per hour per the rhabdomyolysis protocol. After that, his weight was reduced to twice maintenance to avoid pulmonary edema, given his prior diagnosis of cystic fibrosis. Subsequent laboratory testing 6 hours after presentation revealed a sodium of 134 and a CPK of 2,562, despite aggressive hydration. The patient was discharged the following morning with resolution of pain, good urine output, serum sodium 136, and a stabilized CPK of 2,625. He did not suffer any significant renal or muscular complications as evidenced by no muscular weakness, improvement in pain, and normal urination at follow-up with his primary care physician the next week. His serum BUN and creatinine 8 weeks later was 16 and 0.8. The authors noted that at this time there were no evidence-based guidelines for exercising the adolescent population with cystic fibrosis. Most popular tests Textbooks endorse increased sodium intake to avoid hyponatremia, but lack specific recommendations. The Pediatric Nutrition Handbook, published by the American Academy of Pediatrics, advised the consumption of sports drinks that contain significant quantities of electrolytes for this population. That's a quote from the authors. Now, what was recommended for this athlete moving forward was adding 1 teaspoon of table salt to a 20-ounce bottle of Gatorade to increase the sodium concentration of his electrolyte drink. He was encouraged to drink enough to urinate at least every 2 hours and to stop exercise if he was unable to maintain this intake or urine output. Fortunately, the patient returned to competitive football with this regimen and has not had subsequent symptoms. Key takeaways that I gathered from this article. Number one, why are CF patients at higher risk? Number one, they have excessive salt loss with their sweat. The CFTR gene located on chromosome 7 provides instructions for creating the CFTR protein, an ion channel that transports chloride ions across cell membranes to regulate water balance in mucus, sweat, and digestive fluids. The CFTR defect causes hyperosmotic sweat with high sodium and chloride content. Also, there is an impaired thirst response. It's termed voluntary dehydration. The hyperosmotic sweat leads to hypoosmotic serum, which blunts the hypothalamic thirst stimulus. Number two, sports and physical activity are safe and beneficial for patients with cystic fibrosis, with evidence showing improved exercise capacity, slower decline in lung function, and enhanced quality of life. Physical activity is now considered an integral part of multidisciplinary CF care, and adverse effects appear rare. Physical activity interventions lasting over 6 months likely improve exercise capacity. A longitudinal study of 212 CF patients over 9 years found that higher habitual physical activity was associated with a slower rate of FEV1 decline. Patients with higher activity levels experienced a decline of a little over 1% per year compared to almost 2% per year in those with low activity levels. Exercise also enhances mucociliary clearance and ease of expectoration compared to rest, potentially serving as an airway clearance technique. Beyond the respiratory benefits, exercise improves overall fitness, helps normalize the lives of CF patients, and can be more easily accepted than more traditional therapies, reducing psychological burden. And this is key. Greater exercise capacity is associated with improved survival in patients who have cystic fibrosis. Okay, 3, exercise recommendations. Current consensus suggests that exercise as an airway clearance therapy should be aerobic activity of at least 20 minutes duration, intense enough to elicit deep breathing. And the consensus supports exercise during stable disease, but not during pulmonary exacerbations. So those are my key takeaways. Practice questions. A 16-year-old female with well-controlled cystic fibrosis wants to join her high school cross-country team. Her most recent pulmonary function tests show an FEV1 at 78% predicted. Her parents are concerned about the safety of competitive running. Which of the following is the most accurate statement to counsel this family? A, competitive endurance sports are contraindicated in patients with cystic fibrosis due to the risk of pneumothorax. B, exercise is beneficial in CF and is associated with improved exercise capacity and slower decline in lung function. C, patients with cystic fibrosis should limit physical activity to low-intensity exercises such as walking and stretching. D, exercise provides no additional benefit beyond standard airway clearance techniques. E, athletic participation should be deferred until the FEV1 exceeds 90%. Answer, B, multiple studies demonstrate that physical activity in CF patients is associated with improved exercise capacity and slower rates of FEV1 decline. Exercise is now considered an integral part of multidisciplinary CF care. Most patients, including Those with moderate reductions in lung function can safely participate in competitive athletics. Next question. When counseling an adolescent athlete with cystic fibrosis about hydration during summer sports practices, which of the following recommendations is most appropriate? A. Drink plain water and avoid sports drinks due to their increased sugar content. B. Restrict fluid intake during practice to prevent exercise-induced hyponatremia. C. Consume high-sodium fluids in sufficient quantity to maintain urination at least every 2 hours. D. Limit practice duration to 30 minutes to avoid fluid and electrolyte imbalances. Answer C. Patients with CF can have impaired thirst mechanisms and cannot rely solely on thirst alone to guide hydration. Standard sports drinks contain sodium concentrations that may be slightly insufficient for CF athletes. Recommendations include consuming high sodium fluids in volume sufficient to produce urination at least every 2 hours. One practical approach described in literature is adding a teaspoon of table salt to the sports drink, as described in this article. Next question. A sports medicine physician is developing return to play guidelines for a 15-year-old with cystic fibrosis who was recently hospitalized for a pulmonary exacerbation. The patient is now clinically stable and eager to resume basketball practice. According to current consensus, which of the following statements regarding exercise as airway clearance therapy in CF is correct? A. Exercise can replace traditional airway clearance techniques in all CF patients. B. Exercise is contraindicated during the 6 months following a pulmonary exacerbation. C. Exercise as airway clearance should be aerobic, at least 20 minutes, and intense enough to elicit deep breathing. D. Anaerobic interval training is preferred over aerobic exercise for mucus clearance. Answer is C. Current consensus supports that exercise as airway clearance therapy should be aerobic activity of at least 20 minutes duration performed at an intensity sufficient to elicit deep breathing. And exercise should be accompanied by assessment breaths, coughs, and huffs to remove loosened secretions. While exercise is supported during stable disease, it is generally not recommended during acute pulmonary exacerbations. Evidence remains insufficient to determine whether exercise can fully replace traditional airway clearance techniques. Thank you.